Hi, this is Dr. Michael Johnson again. It's been some time since I have spoken with you, but I wanted to talk to you specifically about the new normal. I get a lot of questions about coronavirus, and people keep asking me, when are we going to get back to normal? And I say, this is normal. It's just a new normal. So just get used to it, a new normal. We got used to a lot of things. We got used to this new technology, talking on an iPhone or a phone and uploading it to YouTube. This is all new to me. We got used to SARS and MERS and swine flu, Legionnaire's disease. We got used to HIV/AIDS. It was all new. It's part of the new normal. Let's get used to this new normal. This is normal. When I was young, we used to talk about if you say it, just say it, don't spray it. Part of the new normal is recognizing that we do indeed, when we say it, we do spray it. And in fact, every time I speak, every time I cough or sneeze, I am spraying it. I'm potentially spraying an illness as I speak to other people. I'm potentially spreading illness to them. So part of the new normal is accepting that, and accepting that in order to uh, protect others from myself, I need to wear protective gear. This is not about protecting me, but it's also protecting the public, people with whom I interact on a daily basis. I go to the store, I'm out in public in any event or whatever. I need to wear a protective mask so that when I speak, I'm not spreading potential illness. This is part of the new normal, to wear protective gear. I'm protecting others. As a physician, I've gotten used to a new normal also of wearing protective gear for me so that when I interact with patients, I'm not only protecting them from me, I'm protecting me from them. And I wear this face mask covering my face so that when they speak or when they cough or sneeze, I'm protected. The new normal involves protecting others, protecting myself, and a lot of what I do now is actually new normal. I interface with people with a computer or the cell phone. Telemedicine is part of the new normal. People rather not come to the office, and sometimes I'd rather them not come to the office. I'll talk to them on the phone, I'll interface with them on the computer, and that's how we do. We prescribe, we treat. If necessary, order tests, x-rays, etc., get those results, and then, if absolutely necessary, I will see them. But this is part of the new normal. I want to talk to you specifically about testing for coronavirus. Why we test, who we test, what we test. Why we test so that we can track the disease. The disease is in certain people groups, certain neighborhoods, certain ethnicities, certain environments, specifically environments like prisons and factories, nursing homes. We need to know where that illness is, where those testing is going to come positive most likely, and we also want to trace the contacts of those people. So we track the disease, we trace people who have been in contact with those people or people groups, such that if I'm working in that environment, then I want to know who else I've been in contact with outside of that environment. What family members, what um, relationships that I have that are in that within my work colleagues. I want to know who else I've been in contact with so that I can make sure that if I become ill, I know how to alert them of that illness. And lastly, I want to know how to treat people who are at risk that I've been in contact with. Some of the people may be, as I said, at risk, and I've actually unknowingly infected them. So they need to know that. And the treatments right now are relatively limited, specifically treating cough and cold type symptoms. But on occasion, that person may need to see a physician, see a doctor, or even be admitted to the hospital. So I need to track the disease, trace the contacts, and treat those who were at risk based upon my contact. Whom do we test? Well, we test those who are at high risk, first of all, those who are in specific people groups, those who have certain illnesses, specifically immunosuppressant, people who have lung disease, people who have had transplants, people who have diabetes, people who have those kind of things. Those people are at high risk. Frontline providers, as we call them, first responders, ambulance, police, firefighters, cleaners in the hospital. But again, we test also people who are, this would be like the third tier, people who we want to make sure that population group is not harboring, so to speak, a high level of those illnesses. So why do we test? We test so that we can track disease, we can trace the contact, we can treat those who are at risk. Whom do we test? First, those who are at highest risk, those who are involved in patient care, and I failed to mention this, those who are caregivers. You may not be a health care provider, but you're caring for someone who is at risk. You're cooking for them, you're cleaning for them, you're helping them with their personal hygiene. You're at risk for potentially infecting them without knowing it, so you need to be tested. What are the tests? Most prevalent are the nasal swab tests. We test for the virus in the nasal swab. Can we detect the virus by placing a swab up your nose and looking for it that way? And that takes about 3 to 5 days to get back. There is some degree of false negative. That means either too early to detect the virus, there may not be enough virus there, inadequate specimen, or just not processed correctly. So even if you test negative, you still need to wear protective gear so that you may be asymptomatic, not knowing you have it, and passing it on. So even if you test negative, wear your protective gear. Then there's a blood antibody test. In order for your body to develop antibodies, which are things that fight the virus, it takes about 3 weeks for that to happen. So that test is good for people who have been exposed, who may have had the infection and not known it, and we want to know how they've recovered and what else we can do to prevent others from being exposed. We even have that as a cohort of people whom we want to follow with regard to their symptoms. So this is the new normal. Get used to it. Face shields, face masks. And as those of us who are Christians, we should know that the Lord is always doing new things. And look in Isaiah's, the prophet says in Isaiah 43:19, "Behold, I do a new thing. Now what shall spring forth? Shall you not know it? I will even make a way in the wilderness and rivers in the desert." We are certainly in a wilderness, in a desert of sorts. But God is going to do new things. I'm anticipating great new things. But in the meantime, get used to this new normal. Dr. Michael Johnson, Miriam Medical Clinics, 215-644-8745. The new normal.